Hello, everybody. My name is Dr. Todd Cielo. I've been practicing since 1998. I'm in Tampa, Florida. Over the last 12 years, unfortunately and fortunately, I've been defending chiropractors in court, approximately two a year. I'm actually in the middle of my 24th and 25th case right now, which is a owner and an associate. So over the last 12 years, I've seen a pattern. I saw the pattern within the first 3 years, and I actually wrote an article in Dynamic Chiropractic. So I really tweaked my soap notes a lot over the last 12 years. Every time I go to court, whether it's personal injury and or defending a chiropractor in court, and I want to show you how to streamline your notes. One for medical necessity from a family practice, which means there's no insurance, and I want to show you very similar way of medical necessity in your notes from a personal injury. So our challenges in chiropractic are really documentation. Our documentation sucks. Let's be honest. I went to chiropractic school in the early and mid 90s, and they taught me a travel card. And I did that the first 7 or 8 years of practice. And then I increased it to a piece of paper. And then now we have EHR, which is just extremely easy. Um, so medical necessity in your soap notes. I want you to put the words medical necessity in your soap notes, and I'm going to show you how to do it. It's real simple. And if you have EHR, which all of you should have, no travel cards, please, over the last decade of your practice, I'm going to show you how to have easy drop down boxes. You can copy mine verbatim. I do not care. I'm going to talk about subluxations, locate, define, and quantify. I'm still a subluxation practitioner, but I follow the rules of the AMA guidelines because the AMA guidelines is valued, recognized in court more than the Green Book. And I know you know what I mean by the Green Book. So when I talk about subluxations, I'm talking about them from an AMA guidelines standpoint, and everything from the AMA guidelines that I'm going to talk to you about, we were taught in school. We just didn't know it was the AMA guidelines. I'm going to show you how to objectify an impairment rating so you look unique and different. Otherwise, you're just doing chiropractic and rehab in your office, and you're just generating a final narrative with your opinion. And everybody on this earth, as far as a practitioner, has an opinion. I'm going to show you how to take your opinion out of it, to use the AMA guidelines, to run circles around the board certified radiologist that they always hire to go against me, that I regurgitate the AMA guidelines. There's 6 pages out of 600 that I've memorized. It's 1% of the book that 100% of the attorneys, until they work with me, do not know that they exist. I'm going to show you how to increase credibility in your practice. The medical Bible is the AMA guidelines. It's called a learned treatise. So I really want you to understand the terminology of a learned treatise. A learned treatise is something that's smarter than all of us. It's something that's been recognized in courts for decades. And when I say decades, I mean 40, 50, 60 years. So when you talk to an attorney, you say, I use the AMA guidelines, a learned treatise, and they will look at you differently. We must be patient-centered. If you're not patient-centered, please don't practice. You have to have a paper trail. And when I say you have a paper trail, you have to have what I term dead doctor notes. Dead doctor notes simply means that if you die and another DC looks at your notes, they understand what you were thinking, why you were thinking it, what technique you're using, regardless if they know the technique or not, and why you're performing that technique, what recommendations, and the why. Why is the big deal. And I defend chiropractors. So the first 10 or 15 cases, they were basically all the same. It was just kind of a family-based cash-paying patient that sued the practice, sued the practitioner. The pattern that I saw is everybody came in one time. One time. One time. I really want you to understand this. And the notes that I got from the chiropractor was from one visit. And every chiropractor's notes sucked. So I had to read between the lines. 100% of the chiropractors never took an x-ray. Never talked about an x-ray. Never talked about advanced imaging. Just talked about symptoms. One guy did 47 orthopedic exams, but not one x-ray. If everybody did one x-ray, recommended an MRI, and recommended a second opinion, none of those lawsuits would have happened. But after that first visit, guess where all the patients went? That day or the next day, they all went to the ER. and they said, I got a chiropractic adjustment. What did the ER do? They took one x-ray, one MRI, surgical consult, half of them got surgery. So on every case, there's basically 5 experts going against me. There's always an ER doc, there's a radiologist, there's a surgeon, there's an orthopod, and guess who the 5th person is? A chiropractor. And guess who that chiropractor is? Somebody who doesn't practice. So they're just getting paid to go against us. And guess how many experts the defense has? Guess who that person is? It's only me. And I'm going against 5 experts. So I'm going to show you how I go against them. And I'm going to show you how I do my notes. Medical necessity. Everybody thinks they understand what medical necessity is from a DC standpoint. Justifying treatment. You can say whatever definition you say out loud right now in front of your computer, in your head, but I'm going to show you what I know it is. And I'm going to show you what you're going to put in your SOAP notes, whether it's a cash paying patient, whether it's Medicare, whether it's Medicaid, whether it's personal injury. It's reasonable, appropriate, and necessary in order to go to the next academic step based upon past imaging, current imaging, signs, symptoms, patient presentation, etc. Have you guys ever seen the series Ballers with Dwayne Johnson, The Rock? He's an ex-NFL player. It's obviously drama and it's all fiction, but he's a financial advisor. So since he's an ex-linebacker for the Miami Dolphins, he has headaches, typical scenario, right? So his girlfriend says, why don't you go to a neurologist? Go to the neurologist, you have headaches. So he goes into the neurologist. These are all actors, okay? So I want you to be aware of that. But there's a great line that this actor uses, and I use this on my patients all the time. So the neurologist doesn't even touch him. He just says, how long have you been having headaches? Ever since I retired, blah, blah, blah. He goes, okay, we're going to order a brain MRI. And The Rock, who's the ex-linebacker, he says a very simple question that 50 to 60% of my patients always ask me, whether it's personal injury, but especially if it's a cash paying patient or personal paying patient. They say, Doc, is it really necessary? And the actor, who's a neurologist, gave a great answer. And this is the answer I've been using for about 8 years. It says, we don't know if it's necessary until we get the results. Isn't that a powerful statement? So what I tell patients is, hey, we're going to order an MRI of your spine because I believe there's a herniation based upon your signs and symptoms, based upon your presentation walking in, based upon your x-rays, because I have x-rays in the office the past 25 years. And I love being wrong. I tell patients that all the time. I go, I love being wrong. I've been wrong 3 times in 25 years. There's no herniation. There's no bulge. I was wrong. You wasted $250. Big deal. Now we know. I'd rather have it, not need it, than need it, not have it. That's for imaging. Medical necessity. So here is my first line of my recommendation column on the first visit. Chiropractic adjustment treatment is reasonable, appropriate, and medically necessary to administer due to signs and symptoms of the neck, mid-back, low back, sacrum, segmental dysfunction. Haste, add or subtract to that, whatever levels, I don't care. Because you're telling the world, the insurance company, I believe this is medically necessary. The next one I say, x-ray studies are medically necessary to the lumbar and cervical regions based upon signs, symptoms, patient presentation to rule out instabilities, degeneration, and osteophytic formations. Add or subtract whatever you want in there. Signs or symptoms or what the patient fills out and what you guys talk about. You don't have to riddle it with radiating pain and all that stuff. Here is a blanket. I love this one. I created this one about 6-7 years ago. You can have anything in this. This covers you if the patient never comes back. I explain the patient's current condition utilizing spinal models. How many times a day do you do that? The patient's x-rays, current symptoms, treatment options, diagnostic recommendations to further analyze the patient's condition, and follow with primary for further evaluation. If they don't come back to my office and they go to another office and all I took was an x-ray and I wrote them a script for an MRI, or I told them, hey, I want to see you 4 times. And if it doesn't go down by 50%, then we're going to order an MRI. And they subpoena my records. They can look at this and they say, oh, Dr. Cielo was talking about further evaluation for more diagnostic testing. MRI studies. This is very important on insurance. MRI studies are medically necessary of the lumbar region and cervical regions based upon signs, symptoms, and patient presentation to rule out disc herniations. This is for personal injury and or if you see a spondylo. Stress fuse, CRMA, which is computed radiographic mensuration analysis in the cervical region or reasonable appropriate necessary due to the patient's presentation, signs, and symptoms of their cervical region along with MRI findings. This will allow translation angulation of ligament laxity to be quantified, CRMA, and correlated with the AMA guidelines, MRI findings, and patient symptoms. I put that on the first visit as well. Recommend second opinion for evaluation possible injections, future diagnostic testing with ortho surgical consult or primary based upon symptomatology and patient consultation with MRI findings. I cannot refer them out for that second opinion until we get that MRI. Unless I feel that this patient's going through an event. And when I say an event, I mean a vascular event, which has happened dozens of times in 25 years here. And that is ER time and or ambulance time. So this is basically what I see in every evaluation of the DC that is hired by the plaintiff who is suing the chiropractor. Dr. So-and-so notes suggesting that he offered the patient's x-rays, but the patient declined them, does not comport with the standard of care. It is a physician's duty to ensure safe and appropriate care, and Dr. So-and-so failed to meet that standard by not obtaining radiology images. And this doctor is always at least 10 or 15 years older than me, and I know this doctor never took x-rays in the 60s and 70s. So this is telling the jury that the doctor that's getting sued should have taken at least a couple x-rays. And 99% of the time when they go to the hospital and the ER says, we need to take an x-ray, guess what the patient says? Of course, take an x-ray. I was just adjusted a couple hours ago. And 99% of the time, there's a degenerative disc. And then they blame that on the DC. Okay, so this is what makes my practice unique and different over the last 15 years. We all heard of George's line, right? You guys remember that in radiology class. So I'm going to talk to you like a bunch of jurors, and I'm going to talk to you like you're a bunch of attorneys that I market to, because I market to 50 to 100 attorneys at a time, a couple times a year to get their business, because I want to show them that I know more about the AMA guidelines than their board certified radiologists. And I want to show them that I know more than the average DC, because DCs just talk about, oh, this person has a permanent injury due to these symptoms and due to this MRI. But I'm going to show you why MRIs are losing footing in the personal injury world. So this red line is an imaginary line on the posterior aspect or in the back of the vertebral bodies. There's 4 reasons why this line is broken, not basic reasons, 4 very specific reasons that have been around for over 100 years. 1 is a fracture, 2 is a dislocation, 3 is degenerative change, and 4 is ligament laxity. If it's a fracture or dislocation, the board certified radiologist would have found that on the MRI study. If it's a degenerative change on the posterior aspect or next to that red line, that's telling me that there's a spur. The only way to tell if that is a real break in George's line, you have to do flexion and extension. Otherwise, that is a false break in George's line. And the AMA guidelines ask you to do 2 things with a patient. They ask you to do flexion and extension. And they love that, and they value that view. Do you know why? Shake your head if you know why. Because it's linear motion. Linear motion is non-coupled motion. There is no cheating. So that means in millimeters or in degrees, and if it's over a certain amount, it's a permanent injury. And that is without a herniated disc. I repeat, you can have a 25% impairment rating with 3.5 millimeters or 11 degrees in the cervical region with a negative MRI. 100% of attorneys don't realize that. And the AMA guidelines understands that for one very important reason. And I'm going to go over that reason later in this lecture. So here's the code that I want you to understand is M24.28. M24.28 is the diagnosis code for ligament laxity. There's a few benefits for this code. The insurance companies know that you do not know. The insurance companies know that the attorneys don't know this code. And all the adjusters that are retired that travel the country that talk about what codes to use, this is the #1 code. You're allowed to treat the patient longer. It's a value driver. Every personal injury claim has 51 severity points. So every diagnosis code gives you a point. If you have a 25% impairment rating, every 5% of an impairment rating gives you 1 severity point. So if you have a 25% impairment rating, that's 5 severity points right there. Contusion. How many of your patients have contusions after a car accident? From the airbag, from the seatbelt on their shoulder, from the seatbelt on their stomach, from their knees hitting the dashboard. That's 5 severity points. Is it going to heal? Absolutely, it's going to heal. But those are severity points. Look at that. I really want you to look at this photo because everybody's looking at the arrows. Those are gross misalignments. Look at C2 over C3. That's an anterior listhesis. That's what a radiologist says. A radiologist doesn't read it because they're not a clinician. C3 over C4, that's another anterior listhesis. 4 over 5, another anterior listhesis. 5 over 6, another anterior listhesis. 6 over 7, perfect. And I'm going to show you how I market my practice with 2 simple, one's a radiology point and one's a copy of my alteration motion segment ligament laxity report. And those reports give me $10,000 to $20,000 of business every month. So subluxations. I talk too fast. Everybody good? Subluxations. These are the 4 subluxations that the AMA guideline loves. They love these subluxations. You know why? Because there's linear motion. It's not this. It's not this. It's not oblique. It's this. Anterior listhesis, forward movement of a bone. Retrolisthesis, backwards movement of bone. Flexion. So if my fingertips are anterior, this is flexion. That means you have posterior widening. Extension. That means we have anterior widening of the disc space. No one measures that. And the AMA guideline says measure it. Do you suspect ligament laxity? The answer in a vehicular accident, do you suspect ligament laxity? The answer is yes. Why? Because it's a whiplash motion. I don't care if it's this way, this way. If the car flips 17 times, it's whiplash. And this is out of Yoakum and Rowe as well, all 7 of these. So this is lateral flexion, this is rotation, and then this is lateral listhesis. But the last 3 are coupled motion. The AMA guidelines doesn't care about that. Why? Because it's not linear motion. Why? Because you can't slap a measurement on it. You can slap a measurement on ADP of a mouth for clinical importance, but the AMA guideline doesn't care about it. That Yoakum and Rowe does, White and Panjabi does, but not the AMA. So here is of a 17-year-old. So I have x-rays of 17-year-olds all the way up to 87-year-olds. So I want you to look at George's line. And what you're going to be using right now is your naked eye. There's only 3 ways to measure a bone. You can drag a cursor, you can use your naked eye, or you can plot points of anatomy. I suggest you plot points of anatomy because that's what the AMA guideline asks for. So C2 over 3, you have a small retrolisthesis. 3 over 4, small. 4 over 5, medium to big. 5 over 6, medium. 6 over 7 is perfect. I want you to remember I said perfect because I'm using my naked eye, right? So we're going to go on the P column. P means posterior. So 2/3 is 1.2 millimeters. 3/4 is 2.36. 4/5 is 2.36. 5/6 is 1.7. I really want you to understand that the height of a quarter is 1.75 millimeters. So if you stack two quarters on top of each other, that's 3.5. And by the way, this is on the day of her accident. And by the way, the day of her accident, she had a negative MRI. Here is flexion of the same 17-year-old. 2/3, small. 3/4, medium to big. 4/5, medium to big. 5/6, small to medium. 6/7, small to perfect. Let's go to the A column, which means anterior. 2/3 is 1.86, the height of a quarter. 3/4 is 2.87. 4/5 is 2.48. 5/6 is 1.61. Go to the far right, all the red. If anything is over 3.5 millimeters, this is a permanent injury, 25%. So this patient, which was not given to me until 2 years after the accident, all this information was given to me afterwards, and I'm going to get to that in a second. So the day of the accident, 3/4, 4/5 was at 4.5 and 4.84. The other one was 3.31, which was off the width of a hair. So a chiropractor sent this to me because they came to a seminar just like you guys are. And I asked him, did you order another MRI on this patient? And he goes, no, it was negative the day of the accident. I said, I don't care. It's positive now. He goes, how do you know? I said, because I'm a wizard. Why don't you order it? And I go, when's your depot? He goes, in 2 weeks ago, order it ASAP. He orders it. And where the two ligament laxities are, guess what was there? A bulging disc and a herniated disc. So this is why the AMA guideline says if you have more than 3.5 or 11 degrees, 3.5 millimeters or 11 degrees at any segment, this patient has a 25% impairment rating because they know the future of this patient sucks. The integrity of the Sharpie fibers, the ALL and the PLL are shot. PLL is posterior longitudinal ligament. ALL is anterior longitudinal ligament. This is what the insurance company pays me to do a ligament laxity report. They pay me $700. This is one from a couple weeks ago. This analysis takes me 8 minutes. I don't know how long it takes you guys to make $500, $600, but it takes me 8 to 10 minutes. There's the code. You see the code that I circled? M28, M24.28. It's right there. This is me testifying. They didn't want to pay me to go to Daytona, so they paid me to testify for 3 hours in my office and record this in front of the jury.
Was it? You have an opinion as whether it was reasonably medically necessary for Dr. Stefleck to order that motion X-ray?
It was medically necessary based upon the paper trail prior to that, starting on 10/3 of 2011, and each of those CT, MRI, and cervical static X-rays.
And likewise with Dr. Murphy, do you think his ordering of that flexion extension X-ray that you reviewed, do you think that was reasonably medically necessary for him to order that?
Yes.
Traction bolstering.
And why do you believe that?
Because it's confirming that the ligament laxity is still evident with her cervical spine in the forward and backwards motion, and flexion extension is the standard of care for the American Medical Association.
And do you think it was reasonably medically necessary for Dr. Stefleck to order an MRI of the cervical spine?
Yes.
And why do you say that?
Because when there's the paper trail starting on 10/3 of 2011 and there's suspected ligament laxity that was analyzed objectively forward and backwards at C3, C4, C4, C5, that's instability of those segments. Therefore, after Dr. Stefleck did a motion X-ray and the translation is still evident, it's reasonable and necessary, reasonable, appropriate, and necessary to go to the next academic step to order that MRI to see if any discogenic changes have occurred, and they did occur.
I want you to be aware. Do you notice what I was doing? I was falling on the words of the AMA guidelines. It's standard of care of the AMA guidelines. No attorney is going to object to that. And no radiologist is going to say, oh, yeah, that's ridiculous. That's not right. So all this, and you notice the date, it says 2011, and this is 2016. This is a 5-year-old case that they offered $1,000 to this teenager. Why do they offer $1,000? Because it was a negative MRI. And it wasn't until 2 years afterwards that this case was sent to me. And now here I am playing cleanup years later. And the second MRI is what they were asking me about. Was it reasonable and necessary? I'm the one that told that DC to order that MRI, and her payout went from $1,000 to $132,000. That's how you make a difference. So the number one value driver in all of personal injury, I really want you to understand this. The number one value driver in all of personal injury is a diagnosis. This is on page 23 in the 6th edition of the AMA guidelines, bottom left-hand corner. The guides is value only if the medical diagnosis is correct. An incorrect diagnosis leads to an incorrect impairment rating, period. I could stop reading right now. The most important element of the guides remains a physician's accurate diagnosis. The increasing complexity of the guides and its impairment ratings requires an accurate diagnosis. So the majority of chiropractors that I see, I'm an IME physician as well, all I see is sprain, strain, radiculitis, cervical subluxation, headache, blah, blah, blah. Herniated disc. I'm going to show you why herniated discs don't count anymore, but you could still put it in there because after a certain age, we all have something. And that's why the Mercedes 80s were called the Mercedes 80s, because regardless if you're 15 years old or you're 105 years old and you got in a car accident, if you got an MRI and you were riddled with arthritis, those attorneys back in the 80s got full policy limits by simply folding up an MRI report and mailing it to the insurance company. That's why they're all in their 60s and 70s millionaires, because they didn't have to fight. Now we have to fight. So here's what the board certified radiologists are doing. They're not even using their opinions anymore. This is at the end. This is a disclaimer that radiologists are using at the end of a MRI report. References to causation and permanency follow guidelines established by the American Medical Association. Note, a normal MRI does not exclude certain pathologies, including pathologies avoiding the nerves and facet joints. A normal MRI should not supersede abnormalities detected on physical exam. Disc herniations or contained herniated discs until otherwise specified. So even radiologists are saying, I'm not even going to do my opinion anymore. I'm just going to base everything on the AMA guidelines. And I lecture to radiologists all the time. Here's another thing. This is a funny one. This is when they don't even want to voice their opinion. And this was end of last year. It says it is medically probable that these findings are related to the date of injury, blah, blah, blah. These may represent, here's the key words here, may represent a new disc herniation or a bulge or aggravation of a pre-existing disc disease at these levels. However, correlation with patient's history and physical exam is, so they're not even saying these are brand new herniations. I mean, they're giving the attorney nothing. This is the best marketing I've ever made for myself in 25 years. I made this a couple years ago. So this is a radiology read of flexion extension x-rays. And I think radiologists are the top of the food chain. I think they're one of the smartest doctors on the planet. I have great friends that are radiologists, and I tell them, you guys are too smart. You know nothing about ligament laxity and joint design. And they agree. They're like, I know. I'm like, you guys got to understand what cancer is, space occupying lesion, all that stuff. So this is a typical read if they read a flexion extension x-ray. So anterolacesis, 3/4, 4/5, 5/6. Retrolacesis, 2/3, 3/4. Very simple. We all know what a listhesis is. Anterior, retro, blah, blah, blah. We know that there's categories of 1, 2, 3, and 4. We know that. Obviously, these are all grade 1s. Okay? So an attorney saw these words, attended my lecture, and says, hey, Dr. Cielo, I want you to read these x-rays. Half the time when I read x-rays and I analyze x-rays, I never meet the patient. So I bill $700 in less than 10 minutes, not even meeting the patient because this is an unbiased evaluation. I don't care about the patient's symptoms. Symptoms can be faked. I don't care. Then I got these x-rays and I did my own. So here it is. The anterior listhesis is 1.44, 2.34, 1.63. The retrolisthesis is 1.69 and 2.47. What do you think's more accurate per the AMA guidelines? What the AMA guidelines ask for? They're asking for a measurement to the 100th of a degree. And more importantly, to the far right is where the AMA guideline says, please look, what's the accumulation? 3.91 and 4.16. This person has a 25% impairment rating. I don't care about the symptoms. So I saw a correlation. And the correlation is if somebody has a bulging disc or a negative MRI and they have ligament laxity, years later, they're going to have worse discogenic lesions. So I had a patient that came in, all typical patients. The guy had superior range of motion. He had one bulging disc. He had a positive ligament laxity report over 3.5 millimeters. I ordered another MRI for the case, which was 4 years after the case. And the bulge became a herniation and the adjacent disc became a bulge. So I got that published to make myself look smart and to help out ligament laxity for the chiropractic profession. I'm actually doing another one right now that I archived over 8,000 or 9,000 reports, and I'm getting the average of translation of C2/3, 3/4, 4/5, 5/6, anterior and posterior. So let's see what the 5th and 6th edition says. The 6th edition says flexion extension x-rays stress views, because they're stressing out the PLL and the ALL, provide useful information of the AOMSI at any given level. AOMSI is alteration of motion segment integrity. 5th edition, AMA guidelines. Dominant motions at cervical and lumbar spine where most clinical pathology occurs, flexion extension. Means the same thing. DRE differentiators in the AMA guidelines. Subjectivity, muscle guarding, atrophy, loss of reflexes, loss of bowel control. Oh my God, that's subjective. Non-verifiable radicular pain. Objective findings, electrodiagnostic testing, a bladder study, a cystometrogram, and AOMSI. One of my patients got into a car accident, but it really wasn't really a car accident. A car actually hit my patient. She was bending over in a parking lot in a dealership, and this just settled about 8 months ago. It was a 5-year-long case, and she got hit in her butt by a car. Luckily, she actually had a big butt. And I say that because if she didn't have a big butt, she'd probably be paralyzed. So the car hit her probably going about 10 to 15 miles an hour. It threw her down. She came into my office a couple days later. I ordered an MRI workup on her and everything. She had a couple herniated discs in her back, obvious, a couple in her neck. She had ligament laxity in her low back and her neck. Within a month of care, she goes, Dr. Cielo, I'm peeing in my pants. And I said, okay, so ding, ding, ding. That let off because of a bladder study, correct? I sent her to USF to do a cystometrogram. It came back positive. And we did an entire workup, and their initial offer was $40,000. After I got all the people together and the attorney got the doctors together and all their opinions, they walked away with $985,000 this past December. All because of the workup. Because I covered my butt with ligament laxity. I covered my butt with a cystometrogram. I sent her out to the proper referrals for their scope of practice. She got a series of injections and she got $985,000. We can be objectively accurate or subjectively honest. Mastering the AMA Guidelines, great book. So criteria for AMSI has been revised to reflect current scientific knowledge. Category 2 is muscle spasm, muscle guarding, asymmetry of range of motion, non-verifiable radicular pain, abnormal reflex. All of you are going to have this by the end of this hour lecture. Category 3, weakness, sensory loss, atrophy, radiculopathy, electrodiagnostic verification of radicular pain, 10 to 13%. So all these neurologists are doing these NCVs, correct? You know how much an NCV costs? Over $2,000. Do you know how uncomfortable an NCV is? Have you ever had one done? It is super uncomfortable. And it only gives them 13%. And if it comes back negative, it actually hurts the case. And a category 4, all by its lonesome, AMSI. This is by far the best. This is the best orthopedic study I've ever come across. I got this from a plaintiff radiologist. In traumatic loading, as we see in car crashes and falls, the load is applied very rapidly that such the disc annulus complex becomes stronger than the surrounding structures of the bone and ligaments. I've taken tens of thousands of x-rays in my office over the last 25 years. Have you guys ever seen a Schmorl's node on the end plate? You guys know what I'm talking about? A compression fracture in the lumbar spine. I see that all the time in tennis players, especially gymnasts. And I'm talking young gymnasts to retired gymnasts. And so when you load a disc, the disc becomes so strong that actually invaginates the end plate. That is why the biomechanical community has stated that the disc architecture does not get disrupted in traumatic loading unless the surrounding structures have been altered. What does that tell you? The ALL and the PLL is what is traumatized in this car accident type. This is the chicken the egg theory right now. You have to damage a ligament before a disc gets damaged. And guess what the PLL attaches to? The Sharpie fibers. And what does the Sharpie fibers do? It's a super glue of the disc. So I go against board certified radiologists all the time. I think they're really smart, but they always hire them, the defense. And so I always give a series of questions to the plaintiff's attorneys. So there's an anterior subluxation. This is actually on an 87-year-old patient that got ran over by a van, by the way. Okay. So he goes, what's the cause of a anterior listhesis? So here he is giving smoke and mirrors. He said the degenerative change is the cause of the anterior listhesis. The board certified radiologist says, you see that in almost everybody over 50 or 60, 1 or 2 millimeters of anterior or retrolisthesis. That is a false, incompetent statement. So when they showed me this and I got testified, I said that radiologist is wrong. That's a false statement. As we get older, we don't get ligament laxity unless there's trauma induced. Just because the person has degenerative change. Hold on one second. This is a degenerative change. Can everybody see that? Nod your head. Can everybody see that? So you're telling me when we're 60, 70, 80 years old, this disc is going to move like this? No. This disc is a fortress. And I'm going to show you on a 69-year-old female that this is a fortress until new trauma, severe trauma is introduced. So I shut them down on this one. Here's another one. This is another case. And he goes, and you wrote AMA guidelines question mark on the next line. So this board certified radiologist looked at my ligament laxity report. And the radiologist says, yeah, the AMA has no guidelines for instability. The guidelines that he produced, Dr. Cielo, had to do with determining injuries and percent disability. So this board certified radiologist doesn't even understand that the AMA guideline says if you have a degree of 3.5 millimeters or 11 degrees, that is a new trauma. He doesn't even know that over his own AMA guidelines. The number 2 value driver in all of personal injury is an impairment rating. This is on page 20 of the 6th edition AMA guidelines. If the guides produce more than one method to rate a particular impairment or condition, the method producing the higher rating must be used. Meaning, if you are the treating physician on a personal injury case for a year or two, and you didn't do a ligament laxity study, and the attorney attached to that case sends me the x-rays that you took at your office or you ordered from the MRI company, They send them to me. We both go to court and they say, Dr. Smith, you have here on your notes that you have a permanent impairment rating of 8%. Yes, I do. How'd you come up with that? Oh, because the person had radicular component, decreased range of motion, muscle spasm, herniated disc. Okay, bye-bye. You get off the stand. I go up on the stand. Dr. Cielo, you're saying that Mrs. Jones has an impairment rating of 25%. Yes. Well, Dr. Smith was up here. Who are we to believe? He has 8%. You have 25%. You guys went to school together. What's going on here? Well, you know, Dr. Smith just used a different methodology. He used range of motion and the discogenic lesions and symptoms. I don't use that. I use AOMSI, alteration of motion segment integrity, which is an objective way to see if the bone moved or not per the AMA guidelines. It came out to 25%. And besides, the book says that if there's two impairment ratings, you have to use mine. Subjective complaints alone are generally not rateable under the guides. The height of a quarter is 1.75 millimeters. 2 quarters on top of each other is 3.5. So if the bones anterior to posterior move more than 3.5, that's a permanent impairment per the 5th edition. Or we can measure it with this. I saw the doc here with a white t-shirt holding that up a second ago. That slide rule. You can use that. That's a 26% error rate with a fat leaded pencil. I haven't done that in 27 years. Since 1996, I think.
And when a doctor puts in the report, when dealing with measurements of that you went over in detail, when the doctor puts in his report that he just eyeballs it, what does that mean by eyeballing?
Well, there's only 3 ways to measure a bone. You either eyeball it, you can use this caveman equipment, or you can use a computer. And since we're in the computer age, I advise you use a computer. And in eyeballing it, you're just trying to see if there's wedging, and that's what his report said. He's trying to eyeball angular instability. And in the report it says it was difficult to determine, but what is needed are plotting of those 4 corners of the vertebral body to see those angles go out, and you measure the angles and you compare the angle to the one below, and so on.
So the defense hired a surgeon to go against me on angular measurement, and he has in his report, in quotes, I kid you not, I just eyeball it. And I was trying to be very courteous without telling the world that he's an incompetent idiot. So, because they're going to play this in front of the jury. And I was like, it's not difficult to determine. You just have to plot 4 ends of the cortices. So here's something that they used to ask me over 20 years ago in court. And they still ask me this with x-rays. So I want to go through the scenario here. They always say, Dr. Cielo, when I used to only use MRIs, which the majority of doctors on this planet in the injury world use, only MRIs. I'm going to show you why you don't rely your opinion on the MRI in a second. But they always say, Dr. Cielo, did you take an MRI of the patient the day before the accident? I said, of course I didn't. I didn't know the patient the day before the accident. They go, then how do you know these discogenic lesions came from the accident? It's actually a very good question. I mean, I have to, you know, the defense always has to come up with something good, and that's a good question. And then I simply go by the read of the radiologist. It says it's normal vertebral height. It says there's no desiccation. Therefore, the disc annulus is protruding or herniated due to this. But you really don't know, right, Dr. Cielo? You don't have anything to compare it to. No, I don't, but I'm going by the read of the radiologist. Okay, so now when I do ligament laxity, they go, Dr. Cielo, is it possible? Right when they say the word possible, they want you to say yes. I don't care what the question is. They want you to say yes. So, Dr. Cielo, is it possible that this 58-year-old with this ligament laxity that you say he has, you think it's possible that it came from rugby because he played rugby in his 20s? No. He was a linebacker in college too. Is it possible there? No. He was in 19 car accidents before this. Is it possible he got it from that? No. Because the loss of motion segment integrity is rare unless accompanied by trauma. Is that your opinion, doctor? No, it's out of the AMA guidelines, page 378, 379. So the measurement, you have to understand this. I really want you to understand this. And this is where, when you say the body heals itself, the body heals itself to the best of its ability. That when you have an instability, What do you think the body tries to do over a period of time? It tries to fixate it, correct? That's why we see discs like this in our office 20 years after an accident, because your body does an excellent job. It's not happy, it's just content. It just locks down the joint. So there's no way that when ligament laxity occurs, that it's still going to be moving like this. And when it's like this, in my opinion, compared to this, which looks healthy, this is a much easier joint to injure than this, because this is a fixated joint, hypertrophy of facet joints, osteophytic formations, desiccated disc space. It's a rock. It's basically welded shut. So here's a good example. Do not look at the numbers at the bottom. So I really want you to understand this. So whenever you market this, if you do market this to attorneys, they're always going to give you their hardest case. They're always going to give you a case that's been on the shelves for 3, 4, or 5 years. They're going to see, let's see if Dr. Cielo can give you a silver bullet. It's comical. So they sent me a 69-year-old female, typical grandma, like walks slow, kyphotic hump in her back, walking real slow. And I just roll my eyes. I'm like, great. So I do a flexion x-ray on her. Neutral, then flexion, then extension. Always sets of 3. So when I took the first one, I look at the first one. I'm looking at C2/3, 3/4. All I'm focused on right now is 3/4, 4/5. 2/3, 3/4. Do you understand why I'm saying that? Everybody? Yes? Shake your head. And I'm doing that because I know 4/5, 5/6, 6/7 are welded shut. There has to be so much force in order to make 4/5, 5/6, 6/7 move anteriorly or posteriorly. Even though in studies, women are injured easier than men purely because of girth of neck and musculature. But I still don't think this bone is going to move 4, 5, or 6. So I'm purely focused on pulling a silver bullet out because of 2/3, 3/4. Don't look at the numbers. Now look at George's line, 4/5, 5/6. Is that a break in George's line? So now let's look at the numbers. Go to the bottom right. So anteriorly, 2/3 went 2.49. Posteriorly went 1.52. So I was correct that C2 was my focus, which is 4.01. I can stop right now. She's impaired, but I went to C4/5 and retro went 3.07. The total is 3.99. C5/C6 was 2.92, which is 3.90. So she had 3 segments that were rateable. I only needed 1. We know that the disc at 4, 5, 5, 6, 6, 7 were old herniated discs, correct? Everybody agrees. That's an exacerbation or an aggravation or a permanent aggravation of pre-existing condition. But the herniation at 2, 3, 3, 4 were brand spanking new because of the translation. So I knocked that one over to the park. Now, here's something anatomically which makes me look smart in court. What happens when a bone goes retro? I want you to think about anatomy here. There's no empty spaces in the human body. If a bone goes retro, it has to touch or encroach on something. So for every millimeter a bone goes retro, it's 12% foraminal encroachment. I really want you to understand that. So if you look at the P column at 4/5, 5/6, they're basically at 3 millimeters. So you multiply 3 times 12, which is 36% foraminal encroachment every time the patient does this. And that looks sexy in court. And that looks sexy when you know something that radiologists don't know, the opposing radiologists don't know, your plaintiff's radiologists don't know, and the attorneys on both sides don't know. So everybody talks about, I go to court all the time. I go to court about 5 to 10 times a year. And every time I go to court, I change my soap notes and I relay that information to you because I lecture all over the country, more importantly, the state of Florida. But there's this thing called being challenged in court. And I always tell doctors, if they're not scared of you, they're not going to challenge you. If they're scared of you, they're going to challenge you. They're going to try to what is called impeach you out of court. And they try to do that to me all the time. So they did that to me in 2013. I won the Fry challenge in court. And then 2016, which you saw me testifying, they made me go to court and they tried to kick me out of court because they were scared of me. So Dauber challenge is called a voir dire. If you saw my cousin Vinny, that's what they do to you in court. So I won that. And then I asked them to give me a affidavit. And that affidavit, I said, I want you to say that my reports are relevant and admissible in court because this is the second time in 3 years, and there's no doctor in the United States that have been challenged twice and won. So Dr. Cielo offered testimony regarding the nature of the plaintiff's permanent impairment due to AMA guidelines. And the AMA guidelines is authoritative text, the learned treatise, what I talked to you about, used by medical physicians and chiropractors. That was key. I asked him to put that in the affidavit for us. Dr. Cielo is based upon his review analysis of objective evidence, including the flexion extension x-rays, which the AMA guideline loves. And the plaintiff's treating neurosurgeon also reviewed the flexion extension x-rays. That's the guy that was trying to go against me. Dr. Cielo's deposition of voir dire testimony, he provided detailed testimony regarding his opinions and software program to this issue. I got the judge to sign it. This was 7 years ago, actually 7 years ago this month. And then whenever you get challenged, it's called a vigorous cross-examination. They were yelling at me, screaming at me. The jury's not there. And I won. And the judge is like, Dr. Cielo, you know more about the AMA guidelines than everybody in this court. I go, I know. So give me an affidavit. He said, okay. And then about 5 days later, they asked the judge to go against what he wrote up for me, and he denied him. That's how scared they were. And it went from $1,000 to $132,000. We already went over this. This is muscle guarding, weakness, AMSI. Okay, so this is very important. I really want you to understand this concept. This is on page 383 of the AMA guidelines. This is the bottom right-hand corner. This is one paragraph. I order MRIs on everybody that's in that car accident. So this is dealing with chronicity and acuteness all at the same time. Herniations, 30% of individuals have something by age 40. Aging changes, 40% of adults have something by age 35. Almost everybody has something by age 50. I really want you to understand that. Because below the age of 35, if somebody has a herniation or a bulge, I simply say there is no research study out there that states that it's normal for somebody below the age of 35, especially the age of 30. And if it's a teenager, then I just go ballistic and say, this is ridiculous that this teenager has this herniation or bulge. It is specifically from this car accident. And then on the last line, it says abnormalities on imaging studies does not necessarily mean the individual has an impairment due to injury. Meaning, if they have a positive MRI and they fall into these age categories, it is possible that they got it from age, not from the car accident. So if it's a desiccated disc, like on that 69-year-old female, I want you to write in there permanent aggravation of a pre-existing condition. The key words are permanent aggravation. Who performs impairment ratings? You're going to get this a lot. The attorney's going to say, you're only a chiropractor. It's not going to be accepted by the insurance company. I say, BS. The AMA guidelines, page 23, 6th edition, top right-hand corner. Impairment evaluation requires medical knowledge. Therefore, mostly doctors who are qualified in allopathic, osteopathic, or chiropractic medicine uses the guides. This is the funny part. I love this line. It must be emphasized, however, that even though the guides is written by and for medical doctors, a non-physician evaluator may analyze an impairment rate evaluation to determine if those perform in accordance with the guides. That's funny. A non-physician is going to tell me I did something wrong. That's funny. Our end goal. This is on page 23, bottom left-hand corner of the 6th edition. The guides provide rules, concepts, and definitions to translate this evaluation into an impairment number to assist legal and other systems that calculate compensation. I used to feel weird when the defense would say, Dr. Cielo, it's obvious that you were hired and you're getting paid $1,000 an hour to appear in court so to get this patient money, correct? And I go, no, I'm here to give an unbiased evaluation. Yeah, but if they win, they're going to get money. And now I say, yeah, I'm here to get the patient future damages because they were injured permanently. Hence, here's my evaluation. And this evaluation gets translated into a compensation number by the jury. Absolutely. I was hired for that reason now. Like, I don't even back down. Okay, I'm going to go for a few more minutes because I talk really fast. So I have extra slides. So, stages of injury. We have an acute stage. We all know what that is. We have a repair stage. There's a big timeline. We have a remodeling stage. And then we have a chronicity stage. This is from Arthur Croft. I'm sure you guys have all met him before. Okay, so I really want you to understand this. Thresholds of pain of various tissues, listed in order from lowest to highest. The lowest threshold of pain is the periosteum, obviously. If we have a fracture, it hurts. I mean, how much does it hurt when you hit your tibia on the coffee table? I mean, and that's just a contusion. The next in line is a ligament. And if you've torn your ACL or PCL, that hurts. If you torn your meniscus, that hurts. If you tear ligaments in the spine, that is nociception pain. Tendon, fascia, muscle. So here's the difference of the AMA guidelines. Here's the 5th edition, category 4, 25%. MSI evidence above the threshold, translation greater than 3.5 millimeters or angulation of 11 degrees. Thoracic is 2.5, lumbar is 4.5. And then in the 6th edition, category 3 is 15 to 24%. This is a very key. This is what I said, and or herniation and or AMSI. So if it's a negative MRI, you could still have a permanent impairment rating. Now, ligament laxity is still with vehicular trauma, T-bone. If they get T-bone, I do A to P open mouth, left, right lateral flexion. And then I measure the overhang of C1 over C2. Who wants to jam on that atlas and axis? I don't think so. I'm going to end with a slide. Doctors provide expert testimony, must be aware of their opinions, and must be supported by scientific evidence, or they risk losing credibility. The physician uses the guides, must use objective criteria, unbiased assessment, and all available clinical knowledge, skill, and abilities in deciding whether the measurements, keyword measurements here, and or test results are consistent with the pathology being evaluated. Very important that we use objective evidence. Leg checks are not objective. Symptoms are not objective. Symptoms are subjective, and it shows an evaluation if the patient is making progress or they're static. I understand that part. But when it comes to voicing some type of unbiased evaluation, let's use something that is a non-malingering test, which is flexion extension, which has been around for over 100 years. Thank you very much. My phone number is on the bottom there. Shoot me a text. There's my email. It's Todd@CieloChiropractic.com if you have any follow-up questions. And, you know, Anya, I'd be happy to open up the floor to questions, whatever you want me to do.
Can you hear me? You hear me now?
Yes, sir. Yes.
That was my text. My question was, is there a safe timeline for ordering radiology when you don't perform radiology in your office?
Is this for personal injury?
Yes.
Okay, so when the patient comes to your office and they have not been to the ER or urgent care, it's our
Yes.
duty always to take flexion extension neutral.
Mhm.
The main reason is there for an instability and a
Correct.
chip fracture,
Okay.
hands down. Even if they walk in like Frankenstein and they barely do this, you've done your due diligence for standard of care. I always order MRIs and x-rays the day of the consult for 2 reasons. One, I take the x-rays in my office, but 2, I order the MRI that day because this is what's happened at least 10% of the time in the last 25 years, is when I order an MRI, because I don't care about policy limits. I don't care if it's a $10,000 policy or $1 million policy. But when I order an MRI and it comes out with whatever results, 10% of the time, the patient gets in another car accident within 1, 2, or 3 weeks after that accident.
Yep.
And then the attorney calls me up, and usually the second accident has the bigger policy, or the first accident had the bigger policy. And they say,
Right.
Dr. Cielo, thank you so much for ordering that MRI. We see that there's a migrating disc or the ligament laxity is positive. Now we can differentiate the two claims, because the defense will jump on that now you're ordering an MRI after the second accident. Now you can't differentiate objectivity. All you can differentiate is subjectivity of symptoms.
No, I agree 1,000%. For some reason, I've been doing it, radiology orders within the first 30 days. My thinking was to give the body a chance to heal, to allow the information to subside, to get a more clear and precise image for the patient.
You can, but at the end of the day, still do this. And one, you're going to bill for it because you can bill for it. And then just put in your notes, the patient was really edemic, severe spasm. I will take another set of flexion extension neutral in 3 to 6 weeks when the inflammation goes down. Then you do it again, and then you run your ligament laxity report.
Okay, and MRIs, are you always doing cervical and lumbar, or just cervical?
Always cervical, whether they have radiating pain, localized pain, interscapular pain. And then if they don't point to the lumbar, I don't do anything. But if you feel some spasm, because most people are always going to tell you what hurts the worst,
Sure.
and then they want to focus on that. But then you just say, do you have anything in your low back around your belt line? Yeah, it's a little stiff and sore. Bing, we're ordering an MRI. Because now we're just going by symptoms, and you could have I've seen big fat migrating discs with minimal symptoms, but I'm glad I ordered it.
So my protocol has been, since I've been doing it, is always order the flexion, extension, stress film, cervical, and lumbar. And what I tell the patient is, when I get the X-ray back, if I see something on the X-ray that says, okay, we need to go back in there and shoot the MRI, and what I'm looking for, the spondylos, there's a good chance that we may have to send you back in for the lumbar MRI, partly because I want to overexpose you unnecessarily. Two, they cost a lot of money, so it's going to help you both ways. But we need to go back and shoot the MRI for the lumbar.
Okay.
So that's what I've been doing. So that covers me, or I don't know. Just want to be sure I'm doing everything the right way.
Always, I'd rather have a little too much imaging than a little too little.
Sure. Okay.
Because these patients that love you, when they get in a car accident, you close the case, guess what they're going to do on their second car accident? They're going to come back to you. And if you did not order, say, a lumbar MRI, and now the second visit or the second car accident, they have severe low back pain, and you didn't have one before, and you go to the stand, this is a big policy, you can say, hey, Dr. Cielo, I see here that she had mild low back pain on the first car accident, but you didn't order a lumbar scan. You ordered one this time, and she has 2 migrating discs. Is it possible, Dr. Cielo, that one of these injuries came from the first accident? The answer is yes. I mean, is it possible? Yeah, it's possible. But if you have it and there's one little bulge and now it's a big fat migrating disc, you say, this was a bulge, now it's a fat migrating disc. I know for sure that this is from the new accident. And then the plaintiff's attorney is going to smile and say, I love you, Dr. Cielo.
That's good. Okay.
And that's happened before on a regular cash paying patient that she had low back pain. I ordered it. She had a mild bulging disc, not a big deal. She left, came back a year later, major car accident, and it was in front of a church. She took an ambulance, went to the hospital. They took x-rays. She came to me. I ordered another MRI. She had a migrating disc at the same level. She went in for surgery. The attorney called me up. It was a $500,000 policy. He goes, thanks for ordering that one when she was a regular patient. Now we know this is a differentiating factor. They got the full 500. All because I verified it while she was a cat, because they subpoenaed all my records. And if they subpoena my records and I didn't order that MRI, when I went to trial, they would say, is it possible this was there before? And I would say, yes. But since I ordered the MRI, I said, no, she had a small bulging disc and now it's migrating.
Okay, good stuff. Thanks, Doc. I appreciate it.
No problem.
Your thoughts
Great question.
on DMX in addition to static?
Great question. Great question. So I had motion x-ray in my office for a solid 10 years. And I've had digital x-ray in my office for the past, I don't know, 18 years. I had plain film before that. So this is how I'm going to show you how to market this. I'm going to vomit on everybody right now, but this, you have to explain this to the nth degree, because a lot of attorneys have been lied to for the past 20 or 30 years about motion x-ray. And I want you to understand the nitty-gritty of motion x-ray compared to digital x-ray. Digital x-ray are 3 views. And anytime I do a ligament laxity report, I always do ligament laxity on digital x-ray for 2 reasons. One, they're single views. The insurance company understands single views, and digital x-ray is 10 times clearer than motion x-ray, because motion x-ray has low KVP and low MAS. And it's a pediatric x-ray machine, basically. A motion x-ray, which I love, does all motions. So they do nodding, flexion, extension, rotation, lateral bending, A to P open mouth, oblique. And to me, a motion x-ray study is a qualitative study. I want you to say that to yourself. It's a qualitative study. It's the quality of movement, facet gapping, foraminal encroachment, on lateral aspect, A to P open mouth, etc. But a ligament laxity study, when it's purely, in essence, 1, 2, 3 studies, the insurance companies understand that, and it does not create smoke and mirrors when I get reimbursed for my ligament laxity study of $700 for 8 minutes of my time. Because that is a biomechanical radiographical report, 76499-22. When you use motion x-ray, it confuses the insurance company, and you're using 76496, which is a video fluoroscopy code, and they don't understand that code. Therefore, they down coded the 76120, which is a listed code, and you get paid a lot less. So that's why I use a different code. That's why I use 3 of them. But if you do motion x-ray, do it for the qualitative, not the quantitative, which ligament laxity does, because it's millimeters of linear motion. That was me over explaining it. Give me a call on my cell phone if you want me to explain it further.